afternoon, everybody. Well, good afternoon for me. I'm in Charlotte, North Carolina. I realize there are some of you in the West Coast and other parts of the country and the world that are participating in today's meeting. Let me go ahead and get my slides set up for you all. I have the pleasure and the honor to be able to present to your society today the management of BPH, particularly modern treatments that are in the Boston Scientific portfolio. My name is Dr. Richard Natale. I'm a prosthetic urologist and men's health surgeon based out of Charlotte, North Carolina. I'm the president of Carolina Urology Partners. We are a large urology group practice comprised of 28 physicians, 10 mid-level providers, servicing 12 offices in the greater Charlotte area, as well as the Columbia, South Carolina market, providing healthcare, of course, to all the population, but several specialists in the area of BPH and prosthetic diseases are in my practice. I think when we start off in the discussion of any type of management of BPH, you really got to start thinking about the trifecta, right? We hear about that in oncologic literature in how we do radical prostatectomies, but I think we look at the management of benign prostatic disease in three ways. Our three ways are durability and effectiveness, right? You want to select an option for the patient that's going to work and will last longer than just a few years. Key to that is the preservation of sexual function. We obviously know the differences in things like retrograde ejaculation between the different type of procedures we can offer. And of course, complications overall. So things like urethral stricture disease or urinary tract infections, bleeding, and all the rest. So paramount to that is that you want to offer these treatments to the patient. Gosh, if you can keep them in a site of service that's where they feel most comfortable, particularly in today's day and age with COVID and all the hospitals, at least in my area, being overrun by some of the Delta variant patients. You want to be able to get these patients in and out, treated, and have their problems kind of look behind them now. When we balance things out, we're going to look at the clinical considerations, as we all would, things like a patient's prostate size or the composition, what medical comorbidities may complicate matters, the issues that they have with sexual dysfunction or function at this time, and things like urinary retention. But more importantly, we're also going to look at some of the non-clinical drivers. I think we can pretty much share across the board that the clinical considerations are things we're going to put into each one of the devices and or therapies we choose. But then you have to look at things like cost effectiveness. I think that's a big point that we have to emphasize to ourselves and to our patients. Again, the site of service, where we're getting this done, how long does it take us? Are the patients going to be in the hospital, or will they be able to go home same day? Or can we even translate this over to the office setting as well? And of course, patient satisfaction, which is the thing that kind of drives all of what we're talking about, right? You want to be able to offer the patient a therapy and have them satisfied that what you chose for them or what you chose together is going to be what they needed to treat their disease. So when you consider which therapy is best, I mean, clearly, I think the clinical considerations are going to be the centerpiece of everything, and that's why they can occupy that middle part of our slide, right? So we have prostate size. We certainly have to keep that in consideration. The presence or absence of median lobe. Again, the issues like sexual function, urinary retention that's pre-existing, and all the rest. Then you balance the patient factors of what they want, right? So what they're asking us to provide them in context also of the non-clinical factors we just discussed. So this is where Boston Scientific offers, I think, a unique, probably broadest portfolio of treatment options for patients, right? They're not a one-trick pony. We have the Resume water vapor therapy system, which is an office-based technology. There's a green light laser system, which is most often either in an ASC or in a hospital. Although in my practice, we are able to do in-office sedation, and we've done green lights in the office as well. And then, of course, there is a new acquisition by Boston Scientific of the luminous laser, which now opens up a market for surgeons who choose either whole lep or whole lap as a therapy for BPH. I can tell you that having used the luminous laser as well as the green light laser, I do have overlapping treatment approaches that are very similar, almost a combined enucleation photovaporization technique in order to remove as much prostatic tissue as possible and affect the biggest change in those patients that do select those types of therapies. But let's hone in on the Resume system first. The Resume system, it takes from older technology and really, as we all know, the transurethral needle ablation technologies like Crystiva, and improved upon the science of it. If you look at the convective force of the applied to the tissue, if you look at the heat distribution in the interstitium and what the apoptosis site create in the cells is far more even than it was with tuna, and therefore more effective. And as a result, now you have this minimally invasive office-based therapy where we can affect durable treatment relief, durable treatment with relief of symptoms for these patients. And we also have the ability to treat not only lateral lobes, but we can treat the median lobe as well with the preservation of sexual function. And most importantly, I think what we notice here is the durability at 5 years with a less than 5% surgical retreatment rate. I think that's something that's very key. We're going to hone in on that a little bit. But this is something I definitely talk about with my patients. So if you look here, we have 2 slides. There's the pre-treatment slide of something we've all seen. This is a person that maybe in the years past, I would have gone straight to green light for large median lobe, lateral lobe obstruction as well. This is a pre-treatment video. This is a 6-month post-treatment video of someone who had a Resume. This is in one of the pivotal study patients. We see here the improvement of the median lobe tissue as well as the lateral lobe tissue. That's an open channel, and I know that patient is voiding well. So again, it's the durability. It's the fact that we're able to get these guys that kind of almost surgical appearance to the prostate with a retreatment rate that's so low at 5 years that this is an acceptable option for people, particularly in the setting of the office and in minimally invasive therapy. Now, you see here that all the clinical characteristics that we look for, things like IPSS scores, Qmax, over time in the studies, you see 5 years later that patients have a significant improvement and a durable improvement of their symptoms. And again, I think the fact that we're able to treat the median lobe and do so, and as we'll see in a moment, compared to other minimally invasive technologies, do so, and I believe a very safe and effective way, really sets us apart. The in-office setting is incredible. North Carolina, we are not a very easygoing state when it comes to CON. We have very strict rules. ASCs are not the course of action for most of our private groups in town. In fact, by last count, I think almost 90% of the physicians in our city are employed through the hospital system. Now that does include some urologists, but mostly the specialists are still independent. So we don't have that access to the surgery centers that some of the other folks who are watching this presentation have the luxury for. So in-office is so important for us. And again, obviously the safety profile, the preservation of sexual function. Before I delve into the 2 pivotal studies here for Resume and UroLift, I do want to say that I make the point to my patients in the treatment to explain that this is an injection. I like to differentiate Resume as an injection or almost as a treatment that, as we know, will take time to improve. If you fashion that discussion with the folks with your patients on it being an injection, then they're more ready to accept the period of time they'll have to wait to see clinical improvement. Now, when you compare head-to-head the other minimally invasive technology, UroLift, and realize there were no head-to-head studies looking at the 2 technologies. These are just comparing the 2 studies that looked at the 5-year outcomes now. And if you realize, and I've actually read both these studies, did so for, believe it or not, approving insurance coverage at one point for Resume in North Carolina. If you look, they're almost identically laid out. I mean, the patient selection, obviously the exclusion criteria, patient characteristics, all the things that we need to do in a study, they essentially lined up well. And you see some of the characteristics of these patients here with baseline IPSS scores that are pretty significantly elevated, prostates that are comparable in size, looking at Qmax numbers that are also very comparable. And here's where the power, I think, Resume is that as you look through year 1 through 5, the light blue being prescription therapy, the dark blue being surgical therapy on the left, and of course, in the corollary slide on the right is the LIFT pivotal study with the lighter orange being the medical treatments. That's the key. At 5 years, less than 5% of patients are undergoing surgical retreatment of their prostate enlargement. Now, you look at the UroLift comparative, that's 14%, right? So 25%, 1 in 4 patients at 5 years of UroLift are needing some sort of therapy, and a good number of those are needing surgical therapy. Now, you can retreat with UroLift. You can also retreat with Resume or other minimally invasive technologies. I will tell you from personal experience, patients that do choose retreatment who have UroLift oftentimes have asked me, at least in my experience, to have their device removed. Because remember, again, these are implants as opposed to an injection. There is evacuation or removal, enucleation of tissue, however you want to state that, whereas the UroLift allows for the compression of the prostatic tissue with gradual atrophy of the tissue, but with permanent implants. Now, as we progress on from the minimally invasive therapies down to the office, out of the office for the most part, we see that we have the green light as an option for kind of the rest of the folks we're dealing with. Certainly, it's the number one choice in the U.S. for laser therapy of the prostate. It's usually a same-day procedure. The various comorbidities in the high-risk patients, I think we all know that the bleeding issue that we'd run into with TURPs and someone who's anticoagulated versus green light laser, it's far more superior. It is a therapy that's been around for years. Certainly, I'm young enough, old enough, depending on what your perspective is, to have been involved in treating patients early on with the 80-watt laser. And as things improved over time to the high-powered laser, was able to appreciate the advantages of what improvement in the green light technology really brought to the patient. It's versatile. Technically, you can do huge prostates if you so choose, certainly larger than what you would do for UroLift or even Resume. And if you look at the retreatment rates, of course, these are going to be a lot better because you're actually evacuating this tissue as well. And of course, when you see the key data points here, the retreatment rate about 4.5%, 5% is impressive. Of course, it is online or in par with Resume's retreatment rates, although this is an overall retreatment rate. And certainly, I think a key point on the green light is that 90% or better of patients are going home the same day. Certainly in my practice, that's closer to 100%. There are very few that I like to keep in the hospital. Don't find a whole lot of necessity for it, to be quite frank with you. Most of these patients, the only thing I worry about is perhaps some delayed venous oozing in the PACU. That can be solved typically with a little bit of traction and some irrigation, either manual or continuous, until that settles down. Now, green light obviously is a longer history than either of the two technologies we just discussed. Multiple trials, multiple papers, comparisons of green light to TURP. And what we see is that basically bleeding risk is better. It's equivalent in terms of symptom improvement and measurements of rates and of peak flow rates and all the rest is to TURP. But it results in a shorter hospitalization. It results in shorter degree of time of catheterization. Now, it does have, in some patients, a higher rate of dysuria and urgency. I have found that. I think some of that can be mitigated with two things. I think one, patient expectation education. Two, some medications like Urabel, Proset, any of those kind of analgesics for the prostate or for the urinary tract. As you see here, picking the patients for the green light. Essentially, all the patients that you could treat with Resume, you could also treat with green light, as well as anyone with larger prostates, of course, that fall outside of the normal clinical characteristics for Resume. Per the AUA guidelines, obviously, this is recommended for higher risk patients, those ones who have who need to continue their anticoagulants or antiplatelet therapy, of course. And the rate of bleeding, and more importantly, the rate of transfusion is quite low. So overall, when you compare the two systems here that we're discussing, Resume and Greenlight, I know what's laid out here. I'll give you my own sort of feeling of all this. For the most part, I'm targeting patients and presenting to them the Resume first as an option, provided that they have the correct clinical characteristics. Now, I will tell you that something that's different for me in my practice, now, of course, more in line with the clinical guidelines, is a pre-surgical evaluation, right? Again, as a guy who's kind of straddled the young, old generation, the idea that we could operate on any organ without an understanding of its basic anatomy, volume, clinical characteristics, by how it appeared kind of internally or externally, somewhat mind-boggling. So most of my patients are going to come in and we'll get a cystoscopy and a prostate ultrasound. Now, there are the few that don't want that, and so I might proceed more directly to TURP and kind of explain to them that procedure usually is somewhat independent of size. But for the most part, when you explain to the patients the need to evaluate the anatomy and how that's going to impact your treatment options, they're pretty compliant. So I look at Resume as being my first line therapy. We do the procedure using nitrous oxide in our office, of course, viscous lidocaine with a penile clamp to kind of be held in place for 10, 15 minutes. That really helps in the topical analgesia. It's a short procedure. I mean, even with these larger glands, you're still talking about 4, 5, 7 injections. Whatever you're going to do, you're looking at 9 seconds per cycle. So you're talking about a minute or 2 minutes at most of intervention in these patients. And when you look at that and balance it out with the fact that there's durability at 5 years, it's minimally invasive, preservation of sexual function, I think it's an easy pick for most folks. Now, the patients who either are leery about in-office procedures or are worried about, or perhaps are worried about a more durable treatment option is going to provide them even longer response, then we have the green light laser. And obviously, this is a tried and true technology, and you can offer this to again all the patients that you would for Resume, and of course anyone who's outside of the Resume characteristics. And key to this entire presentation is what I find unique about Boston Scientific, again, is that we have the boxes checked, right? We're trying to find that balance. And I think I started off the talk today with balance, the idea that we look at what the patient wants, we look at what we need and what we want as physicians, and try to lay out the best course of action for our patients. Ultimately, I think that what makes BSC a unique company in general, but also in this particular market, is that they think of all the options and they have their bases covered. So when you're looking at who to treat and how to treat them, just remember that they kind of cover all the bases. As I said, we start off with the small obstructing prostates all the way to the very large prostates, or certainly the clinically more difficult folks to deal with, and anything in between. That's it for my presentation. I wanted to thank you again for the opportunity to present today. I believe there's a question and answer period that will be after my presentation. Thank you very much. Everybody stay safe. And I hope that we can finally get to do an in-person meeting one of these days. But y'all have a good rest of your day and your meeting, and I look forward to talking to you.